My name is Jaikishen. I work with Dr. Harris, Dr. Lindbergh, Dr. Morris with Renal Nephrology. Thank you for giving me some time today. Hopefully I don't bore you. Louder? Trying to get as close as possible. Is that better? Better? Alright. Yeah. Should I see you?
Oh, yes, much better.
Okay. Alright. My name is Jaikishen. Nice to meet y'all. I work with New Orleans Nephrology here. So I have no disclosures, not yet, maybe Monday. Just before I start, the topic was introduction to CRRT. When I was in fellowship, my attendant the first day said, "Do you know how to use Thor's hammer?" I said, "No." He said, "Well, that's Thor's hammer." He said, "Learn to use it and respect it." So that's what we used to call the dialysis machine during fellowship, training LSU. I'm originally from Lafayette. For fellowship, I went back over there. I was working. Then my wife called me and said, "I'm pregnant." So I drove back over to New Orleans. And that's how we ended up in Metairie. And I met Dr. Harris, and the rest is history. I just want to thank everyone for a warm welcome in East Jeff. Enjoyed myself here. So before I jump just to the modalities of CRRT, because anytime you open up any kind of CRRT text or book, this is what you see. You see just, and then you start to see, okay, perfect. You start to see acronyms. And I thought, let me just take a step back, and then if I explain a couple modes of different types of dialysis that we have, then all these acronyms make sense, and then you can understand when you see certain studies why certain patients do better with certain types of dialysis and where it's really indicated. So what is dialysis? Obviously we all see it. It's essentially a process where you have a solution A and it's run against solution B, and then you alter the composition of solution A. The alteration takes place through a semi-permeable membrane. That's the dialyzer, or the kidney in your body. The main thing is you obviously want a semi-permeable membrane because you don't want everything moving out. So it's against molecules that, sodium, potassium, things like that. And you're trying to keep out proteins so you don't lose albumin and things like that during dialysis. The least controversial thing is acute indication for dialysis. I won't be talking about early versus late initiation for dialysis because that's itself, you'll see different papers every year. But this no one can argue with, which is refractory acidemia, electrolyte abnormalities, most commonly potassium, especially hyperkalemia. Intoxications, volume overload, and uremia. Intoxications is the one thing I just want to highlight right here. This is actually the main indication for regular dialysis because of the blood flows. So if you get like an ethylene glycol, which we actually had here a couple weeks ago, or lithium poisoning, or any of the intoxications, you actually don't want to do CRRT here. But for everything else, we'll get to next. So the basic objectives is just know when to dialyze someone, at least the basics of CRRT so that you have some foundation. And then the advantages and disadvantages, and really who to use CRRT for. And just to break it down further. So before we get to dialysis, obviously, hopefully we've seen the patient. There's non-dialytic management of acute kidney injury and dialytic management of acute kidney injury. So usually this time we've tried to do the former, and once we've decided we need dialysis, the Achilles heel of nephrology is access. So a lot of times we have to ask for, temporary access or tunnel catheters, but most of the time for CRRT, acute dialysis, we're using temporary catheters. I just want to, thank the radiology colleagues here for timely catheter replacements. I used to have to do that in my same day, every day, and it made for a very long day. The main thing is it sits right here, internal jugular, the preferred site. Femoral site is actually acceptable. Left internal jugular actually gives us the most problems because that's the curve around. So believe it or not, we'll actually go IJ, femoral, and then if we really need to, we'll do a left femoral, left IJ. So the mechanisms of solute clearance. So this slide, if I could, with a couple minutes, just explain the different types of modalities of clearance then those acronyms will make sense. So the way that a dialysis machine performs dialysis or clearance of solutes is either by diffusion, convection, and those are the two main types of clearance. Diffusion is what everyone is familiar with. This is what you first think of. It's a random movement of molecules through a membrane, basically from the larger side to the less concentrated side, which I think everyone probably remembers from, I guess, chemistry or something. Essentially, it's pretty simple. You run your blood through here, your dialysis flow runs opposite countercurrent. There's your membrane, and then you get dialysis right there. The way we do that in a regular, so this would be the movement. You're running a lower potassium in your bath, a higher potassium in your blood. That's how we balance that out. Just want to make a note on dialysis fluid, because being an introduction to dialysis and CRRT, in this hospital we use SLED, so I'll talk about that in more detail than the other methods, because that's what we see every day. And if we ever switch machines later, then we can always talk about that another day. But most of our baths, if you ever look at the bottom of the machine, you're going to see two jugs like this. One's the bicarbonate and one's all the electrolytes. And what's interesting here is the bicarbonate buffer here is actually sodium bicarbonate. Years ago they had tried lactate as the buffer. Patients actually didn't do that much better, in fact a little bit worse with the lactate arm, so they go with sodium bicarb. My wife's critical care, so every time we used to argue about can you give bicarb, is bicarb safe or not? I mean, yes, there's a risk sometimes with severe respiratory acidosis, but a lot of times with them AKIs and acidemia, whether you give them bicarb in their IV or bicarb through their dialysis, it's actually the same sodium bicarbonate. So after that, whenever I tell our attendings that, they always be like, what? So anyway, the other second thing is, if you have the actual CRRT machines, which I'll show you later, they actually all have pre-packaged bags that you get from the factory. So if you have to modify that when you have someone with severe acidemia, you actually end up having to, because contracts will never allow you to just add more bicarb to the bags, you actually have to add a separate bicarb drip. So whereas in SLED or in dialysis, we can actually just dial up the bicarb, where I'll show you the buttons later. So it's a little bit easier, I find, but it's whatever you're used to in any hospital. So this is just a picture of hemodialysis. Obviously, this is looking at it slit, but it's blood moving through into the dialysis through the membrane. Ultrafiltration, I just want to touch on this being an introduction, is this is when, if you ever say, oh, we UFM only, it's just taking fluid off, not solutes. And the way this works is you basically, just the dialyzer, you have a pressure at the afferent end and pressure at the efferent end. And it's basically the higher pressure here forces the blood through the dialyzer. The force of that then pushes the water out. There's something called a TMP pressure, which I'll show you later. But that is how we're able to actually suck out the water and not the solutes. We use this in patients sometimes if they can't tolerate fluid removal and dialysis at the same time, we split it. But this is just nomenclature, so if you ever hear the term UF only, this is what we're doing. Hemofiltration is the second form of solute clearance, which I was talking about, which is convective clearances. So standard machines, anytime you read the literature, you'll see CVVH or CVVHF or CVVHDF. So these machines are programmed to do hemofiltration. So the setup, I have a diagram later, but essentially it's how ultrafiltration works. Instead of running your dialysis opposite to the blood flow, you actually run a therapy fluid or their dialysis flow with the blood pre-filter. You push that through the membrane, and I guess if you could picture, you have I guess if you're washing your patio or something, and you got, you make like you got leaves or something, you force the water through and it forces the water out and everything. That's essentially what this is you have high pressure at the beginning of the filter, pushes the blood through. The pressure of that then forces solutes to follow when the water goes through the membrane. So that's essentially hemofiltration. So what is CRRT in comparison to IHD? It's essentially slower blood flows. It's more gentle. It's to allow for improved hemodynamics. It's we think that it causes less change in plasma osmolality. There is this syndrome called dialysis disequilibrium syndrome, where if you have high BUNs, you can cause rapid shifting with regular dialysis. The thinking is that because we're doing this at slower rates, you have less shift in your plasma osmoles. The next thing is, since it's kind of like real-time dialysis, meaning you can get labs, adjust your settings, as soon as the lab results come back. get pretty good control with azotemia, electrolytes, and acidosis. The only thing here, again, with this sodium is when you are using an actual CRRT machine in a prepackaged bag, they have a fixed amount of sodium, so those patients have to be a little bit more careful with. Whereas in a regular dialysis machine, you can actually, again, adjust the sodium for what you want. And it's ICU friendly in one way. It's hard on the staff the other way. But the reason it's friendly is most ICU patients, by the time we walk in, they already have a Christmas tree of stuff. They have medications, they have pressors, they have TPN sometimes. And obviously, if they're on CRRT, you can ultrafiltrate all that off, so you avoid life aims to get them less ventilator days. So now with that introduction, I just want to spend a few minutes here. So if you ever, when you see like a regular dialysis machine, that's IHD, that's intermittent hemodialysis. These, this form of dialysis is usually between 2 and 4 hours, and this is what everyone thinks of when they think of dialysis. The blood flows here, so like I said, the main thing is blood flows. So the blood flows in an intermittent hemodialysis machine, you're running anywhere between 300 and 400. Like patients in the chronic unit, we run their blood flows at 450 through an access. When you're talking about CRRT, they'll recommend blood flows as low as 50 ml a minute to 100 ml a minute, sometimes 200. If you're crossing 200 ml a minute on CRRT, you might as well go to hemodialysis. There's no point stressing them that much on a CRRT machine. Usual blood flows is going to be 150 to 200. When you run your blood flows very low, you run clotting, but I'll talk about that later. So CVVHF is the default method. Anytime you read like CVVH or CVV, the method of clearance will be convective clearance. And these are normally machines like this. This is like a next stage machine. Fresenius, the company we work with, actually bought this company for a couple billion. This machine actually started off as a home dialysis machine. Because it's slower dental rates at home, they actually flipped the market and got into CRRT. These machines run for like 36 hours. At still 24 hours, you have to switch out the cartridges. This is the Gambro machine. This was owned by Baxter, now DaVita, the other company. I love watching corporate America. They just buy each other out. But this machine can run hemofiltration, hemodialysis, and hemodiafiltration. So anytime you see these three methods of clearances, those are different types of machines. So I want to spend a little bit more time here with SLED or SCOP. This is actually PIRT, which is prolonged intermittent replacement therapy. So before I go any further, I was just reading our latest NEFSAP to make sure stay up to date. But they actually ran a couple studies this year to show SLED, what we use, in comparison to the CVVH machines. There's actually not that much difference in mortality, ICU days, and even cost is actually a little bit less with the SLED machines. I think the main thing is because it's the same machine. So this is regular dialysis machine. This is one. This is actually, I took a picture of this. There's no patient data, but this is actually on the dialysis floor. Same machine. If you flip a switch, you can run it as a CRRT machine in ICU. The way this method of dialysis came about is essentially as a bridge. You run, so if a regular hemodialysis session is 4 hours, then this SLED treatment runs about 8 to 12 hours. 8 hours of SLED equals about 4 hours of dialysis. And the way you come up with that is your blood flows on SLED will be about 100 to 200 ml a minute. So that is just the same treatment, slower. Same machine, slower. Same type of bats. That's why you see the same jugs, but slower. Now, obviously, sometimes we can't take patients off at 12 hours for various reasons. Then these machines can run longer. They do run longer. We see them here run longer all the time. But after about 22 hours, we still have to break them down, change up the circuits, and then start them back up. The other way is, how do you decide what you want to do on the patient? Well, a lot of times it depends how much fluid you want to take off, or how sick are they, or how acidemic are they. And that's kind of how you come up with a prescription, like, all right, let's take a liter off in 12 hours. Obviously, it's much more gentle than trying to take a liter off in an hour, right? So that's essentially, look at the patient, how much you want to take off, what are the labs, and kind of, I'll show you the settings later. So one more thing I want to touch on is dialysis before the addition of this blood roller pump right here was actually incredibly scary and difficult. I remember my mentor last year was talking about when he finished fellowship way back. they would use the patient's blood pressure as the actual blood flow rate. So they could not ever control how much blood flow ran into the machine. So that's why you heard of all these gruesome disasters. You also, at that time, they would use CAVH. I can't even say the acronym anymore, but it's continuous arterial venous hemofiltration or hemodialysis. So what was the difference between CVV and CAV? Well, we just have one line, right? So it's all veno-venous. Before, back in the day, they would have an arterial line and a venous line in every patient. So obviously that's where you always hear those risks, and you see on those consent forms, air embolisms and everything were very common. Every time for dialysis, you couldn't just leave the line in. You had to stick in an arterial line every time, and a venous line every time, take them out in the dialysis, and then stick them back in. So that's where all these, you hear the complications come. It's all, it still happened, but much, much less. But before they had the addition of this blood roller pump, you had to, I remember George talked about like injecting, phenylephrine or vasopressors into the blood circuit to raise the pressure right before it got to the machine and then off. So what happened was we had these patients, septic, dying, would get on the machine, somehow make it through, get off, and then they'll crash right after because they didn't have pressure support, they didn't have anything, all to maintain your blood flow rate. So I think we're pretty spoiled. I just walk up to a machine and dial up casually what I want for my blood flow rate, and it does it. The machines are very, very nice to work with. Anyway, so the main thing here is blood flow coming in into the roller pump, there's the air detector, runs through the filter, and then goes through the patient. And obviously this is dialysis would be or diffusion is the mode of clearance. Just want to show the screen. This is what we look at sometimes. If you ever see our mysterious orders, most times I never write this in a note, I'm trying to move, but these are the settings that we do. This is kind of cool with SLED, is we can actually adjust the dialysis. So sometimes, they'll say, IC nurses, they acidemic, what do you want to do about it? We can dial up all the way up to 38. 36 is usually where we keep it at, as the highest that I don't feel comfortable giving more bicarb than that. If they're running for like 20 hours or so, we can leave it at 24. And about 6 hours, you start to see labs, like, it's pretty cool. After about 6 hours, when you check CRRT labs, it starts to kind of balance and they all look perfect. It's because we're running a physiologic bath. And that takes about 6 hours. And then we can adjust calcium, potassium, mag is a fixed amount in the bath, and dextrose is fixed too. So potassium, sodium bicarb is what we mess with the most. This is the other screen, just kind of tells us how much are the needles working, if the arterial pressure, there's a lot of sucking going on, is there venous pressures going on, and TMP is pressures inside the actual filter. So if you're running clotting, you'll see a high TMP, or you'll see sometimes an elevated venous. So it depends. That's some of the metrics that we're looking at on this machine specifically. So the next stage machine, I used to use this in some of the hospitals I worked at. It's fairly simple, I guess. You have 3 modes that you set, and the reason I want to bring this up is you set your blood flow rate, how much fluid you want to take off, and then there's something called a therapy fluid rate. So later I'll talk about dose of dialysis. And that's essentially, so anytime you read any CRRT literature, you're talking about how much therapy fluid you want to run through the machine. And so those machines just work different. So if you're reading anything about CRRT, our machines don't do that, but maybe one day if we buy new machines, but they cost a lot. Same with, okay, so this is the Gamma machine. This does the 3 types of dialysis. The only thing that I want to touch on is the only one type of hemodiafiltration or CVH that may help with mortality is this one, the Gamma machine. It's like a 1% decrease in mortality, but it's not proven in every other study. Otherwise, they'd be in every hospital by now. So this is just how we set them up. Set up the lines for CVH. We have the filter right here. The replacement fluid can either go pre, post. If you run it pre, you end up diluting, less chance of clotting, but you also can sometimes dilute your clearance. On our boards, we get to calculate that. It's fun. Diffusion, same. What happens is, so a CVH, what's important is you have your blood flow, everything's coming through the dialyzer. If you run it pre, everything's coming one direction. But when you're running a dialysis circuit, you flip the filter, you have a blood flow one way, and a countercurrent, you have the dialysis flow the other way. These are just therapy options that we kind of touched on, CVH, CVHD, and SCUF is just the way that the setup looks. Just want to touch on dialyzers real quick. This is the kidney, specifically. We'll see this filter seen sometimes. I just want to throw this slide in because in the chronic unit or in regular dialysis, we'll be messing with the filters for improved clearance. But when we're running SLED, we're running the smallest filter at a 160. So what are we, this is the next stage filter, but just characteristics of a filter. Whenever you read any CRRT literature, you just want to see what peak and see what kind of dialyzers using, what machines they're using. Efficiency refers to how much urea you can take out in a specific amount of time. Flux is the actual pore size. So the higher the flux, the larger molecules can pass through. Ultrafiltration coefficient, every dialyzer is rated to take off so much fluid. So that's what that refers to. And then mass transfer is another ability to calculate how much can be taken off. So clearance is basically everything we're doing in dialysis is how much are we able to remove in a specific set period of time. I had to memorize this during fellowship. And then it's just a slide to say that all of this put together gives us our amount of clearance that we get during dialysis. So I just want to touch on this one slide because everyone wonders how much fluid we can take off. We can take off as much as the machine will go up and until the patient crashes. But to be safe, there's something called plasma refill rate. That is about 5 ml per kilo per hour. So a safe fluid removal rate is about 8 ml to 10 ml per kilo per hour. So that's, I guess 70 kilo used to be the old, I just use 100 because most people are not 70 kilos. But it's between 800 to a liter of fluid that we can take off pretty safe. That's a good bit of fluid. But this accounts for everything in the hour, medications, pressors, TPN. So that's why a lot of times I like to talk with the nurses about a net UF because their hourly UF changes based on whatever they're getting ordered, or that changes hour to hour. So a net UF, I like to stay pretty conservative, about 200 net an hour. So you're still running about 500-600. So I stay around the 8 ml per kilo per hour for safety. I'd rather run them a little bit longer if I have to. So this is just the literature where we got this. They did a 5-year study on outpatient units, and the patients who are had a higher UF than 13 ml per kilo, they would come in, 6 liters over, and some units would just pull it. They did not do well over time. So now finally Medicare puts this as a metric that we can't remove too much fluid in a session, but I think it makes sense. I don't think we need that as a metric. So just the technical issues to see what differentiates CRRT from regular dialysis. Main thing, I think I talked about this enough, is blood flows. And I just want to touch on CRRT blood flows and clotting. So to prevent clotting, I know we all talk about clotting in ICU, but regular patients clot too. I was rounding last night at the dialysis unit, someone clotted as I was talking to the next person. So clotting occurs all the time. Well, what can we do in CRRT specifically to mitigate that? Well, one is blood flow. If you're running the blood flow rate of 50 to 100, it's very slow, and usually that person's extremely sick. It's better to just improve the pressors or increase the amount of pressors and try and get the blood flow rate. This is my experience, it's not literature, but if you're running blood flow between 150 and 200, 175, they normally don't clot that much. But if you're practicing, you want to be very slow. If you're running blood flow at 50, it'll clot repeatedly, and then you're wasting blood, you're wasting supplies, you're wasting cost, you're wasting time, and you're not dialyzing the patient. So I like to run around 175, 200. And then the most common method of prevention of clotting that we do here is pre-filter, a saline pre-filter. And you'll always see a bag pop up in your order set, but that's really just saline running through the filter to dilute to prevent clotting. If that doesn't work, you can use heparin if there's no contraindications. So normally I'll consult everyone on the case to make sure it's okay if I give a little bit of heparin. But this is the ACS protocol dose of heparin. It's not the full PE protocol. And then there's something called citrate or regional citrate. And this is essentially you run citrate pre-filter and calcium post-filter. So citrate, what you do is it binds to the calcium. You prevent the clotting cascade. And then obviously you're going to lose calcium. So then post-filter, you have to infuse calcium. This is a technical recommendation on SLED. However, the saying in CRRT is the most successful dialysis is the easiest to organize and the least expensive and the most cost-effective, really. But saline pre-filter runs, you don't have to check as many labs. If you run citrate, not only do you run your normal labs, your CMP, MAC, FOS, but you have to get your ionized calcium, a calcium, and then check your bicarb every couple hours. Also, you can't use citrate in someone with liver failure because then they can't break down the citrate and they get metabolic alkalosis from that. So that's usually my last resort, just because I'm trying to make life simple in an already unsimple situation. We're fighting nature at this point. And then the dose of CRRT I just want to touch on is 20 to 25 ml per kilo per hour. This was based on the VA trial and the Renal trial. this is, if you ever read this in anywhere, in any ICU literature, what they're referring to is, I was showing this, this machine right here, you have this therapy fluid. So that number right there will do 20 ml per kilo per hour, so about 2,100 to 2,500 per hour, or 2.5 liters essentially of therapy fluid per hour. So this net dose of CRRT fluid is the effluent. And what this means, you'll see this written everywhere, and what this means is the amount of fluid we gave plus the amount of fluid we take off. And that's considered the effluent. So that's why you don't always have to run it that high, but we always run around 30 ml per kilo, or I used to when I use these machines, because you always have to factor in for downtime, radiology, surgery. Patients aren't going to be on dialysis the entire day, right? So you always want to run a little bit higher to factor in for downtime. So again, just a quick comparison. It's all dialysis. CRRT just refers to slowing down. If we use the newer machines, then it's a different type of clearance, convection mostly. But the machines are totally different, and the setup is totally different. So that's why a lot of times the cost is more, the fluids are more, you're paying for the machines, extra for the labs, and or replacement of electrolytes. Anytime you keep someone on dialysis for longer than 6 hours, you start to lose MAG costs. They're not in the solution, so you have to keep repleting them. So there's that cost. Also, testing downtime. Sometimes they run into clotting. Equipment, you have to buy an entire set of new equipment. Staffing is probably the most logistic for any hospital anywhere. You don't have ICU nurses everywhere all the time, so you don't want to burn your staff out either. And then it always requires an HD nurse for setup. Bicarb, I touched on. Most CRRT machines have fixed bags of bicarbonate, so we have to keep that in mind. And obviously the most, the main indication for CRRT is in your sickest, most hemodynamic patients. These are usually patients we've tried regular dialysis on, so at this point in time we're essentially saving their life. But like I said, I save lives over 12 to 24 hours. So, they're already on pressors, they're already on a bunch of things. So it's like a last resort type of thing. And I'd say it works out pretty well for most of the time. But remember, the bigger question is, does this person need dialysis or not? That's a different situation. That's the bigger picture. But we can dialyze almost anybody. These machines are awesome. Just real quick, again, just to touch base on is that regular dialysis machines are almost available everywhere. We call it dialysis nurse. But poisonings and severe hyperkalemia, you have to do regular dialysis because of the blood flows, you get better clearance. So if you get intoxication, you don't just do CRRT. If you want, you can do the initial amount of hemodialysis and then flip over to CRRT if you want to do it overnight. But that's just for, I'm going to leave that. The only other place that CRRT is a must, this is like a gold standard, is if you have severe intracranial hemorrhage or risk for intracranial herniation. Here, neurosurgery likes to do CRRT. They believe that because the osmum shifts, you have less chance of herniation in comparison to hemodialysis machine. They also like the way you can check electrolytes real time and adjust it. So this would be the one place that you would want to jump straight to CRRT and not even talk about doing regular dialysis. So again, how you decide, well, who's the patient, what kind of kidney injuries is it, what are the hemodynamics, how much fluid you take off, and are there any specific indications for either type of therapy? So that's that. Weaning of CRRT, you'll see like a little subset on this. Essentially, it's, are they making urine again, or is delta creatinine, is it still up? Normally at this time, after about a day or so, actually our partner, we practice about the same. We'll run them initially, maybe run them the whole day, and then kind of give it a break to see what's going on, and then kind of go from there. That's essentially weaning of CRRT. I think they try to do this to be like a pulmonologist, but we're not sophisticated. Only thing I want to touch on is nutrition. AKI is catabolic. They lose a lot of protein during CRRT. It's about 10 to 15 grams of amino acids and 5 to 10 grams of protein per day. So at this point in time, we like to make sure they're either eating or they're getting TPN. This is the only reason I bother anyone to say, are they eating or not? I'm not trying to get your business. I'm just losing protein when they're on the machine. So that's just one of the support. We like to feed them a good bit. 2 kilocalories is the goal, but we also can get them there. And on PRT, which we're doing SLED here, additionally a little bit extra protein. We normally put all patients on dialysis on a renal vitamin or nephropap. Because dialysis is through water, you lose a lot of your water-soluble vitamins. So this is the reason we put nephrocaps. If you're wondering why you see a random order, this is why. So thank you, my little buddy. Any questions? Okay.
How about the platelet drop? How often does it happen on CRRT? Any platelet?
It happens sometimes if they have a dialyzer reaction. It depends on the type of dialyzer. Some are gamma radiated and some are like alpha radiated, non-gamma, I guess. I don't know. But the gamma radiated dialyzers are not associated with the with platelet or drop in platelets. These OptiFlux filters, they can cause thrombocytopenia. So at that point in time, I was wondered actually, because then you have to do a special order, which we do have here. I think it's called the E6. So I used it a couple months ago. I had someone drop on the first couple hours of dialysis. Second, you want to check if they're using heparin or not. We normally don't use heparin first line, but a lot of times they're using heparin second. But it can happen. That's probably the most common dialyzer reaction that I've seen. I haven't seen too much of the old reaction where they have actual anaphylactic reactions on dialysis. But dropping platelets does occur and pretty frequently. I mean, a couple times a year I've seen it.